right, we have our first panel of the day, so maybe I'll ask our panelists to come up and join our moderator, Sean.
Hey, Bill. I was going to say that all the panelists know who they are, but Griffin doesn't know who he is. All right. So it's my deep pleasure to introduce this panel of really what I2B2 is all about, which is, allowing hospitals to enable their data to be used for lots of different kinds of research in public health, basic research, genomics, across the board. And here we're going to see some really great examples of these networks and how they support public health. So I'm going to start by introducing Bill Adams, who is one of my close colleagues, and he's going to talk about Boston HealthNet.
Thank you, and it's great to be here. I'm going to give you a really quick tour of an application that we've been working on the other side of town, Boston Medical Center, the largest safety net hospital in New England, and then also a project that we're working on in combination with the Tufts CTSI to begin to bring data from multiple institutions together to study population health. Is that working? There we go, cool. All right, so maybe 5 years ago or so, we started this journey. Our goal was to use our common data models locally. So at Boston Medical Center, we integrate our data from the hospital and 7 federally qualified health centers in Boston too. So we cover a large proportion of the inner city of Boston. And we wanted to build a platform that would be easily shared with other folks that could really support any computable health outcome, that could account for a broad range of demographic, social, and environmental. So from the beginning, we've been using FIPS codes and zip codes to link external things about where people live and the health that they experience. And to be able to visualize that data using graphs, tables, maps, and some statistics that could expand over time. We wanted this to be open for the community to share. We wanted the code to be easy to share as well. We wanted to leverage common data models, and for us, we're using OMOP right now, but there's no reason this same approach couldn't support I2B2 or PCORNet in the future. And we ultimately wanted to come up with a CDM agnostic data mart where all kinds of different systems could contribute to a simple, I would call it pragmatic approach to organizing and storing data in a way that could be reused in all kinds of different ways. And this is a collaboration between Boston Medical Center, Boston HealthNet, which is the network of health centers that in Boston that work together, the CTSI, and a company called Absalom that's helped us a lot with our software development. And at the core of the system it's pretty simple. We have a library of health dimensions, which are really the status of a condition among people with a condition. So like people with hypertension, is their blood pressure controlled? People with diabetes, is their diabetes controlled? We have prevalence conditions like, do you have a certain condition within a standard population, like people who have been to the health system within a certain amount of time or are seeking primary care. And then we have a whole portfolio of attributes that can be used dynamically to explore the relationships between these exposures and the outcomes. There's a lot here, but simply we take data from our common data models. We have a easily accessible set of R SQL code that generates the outcomes. Most of our outcomes are annual outcomes, so we don't have to have dates. So like it's on your most recent blood pressure. If you're a patient with hypertension, in a given year, was your blood pressure controlled? We have a whole set of health dimensions. We have our attributes, and then we have a portfolio of publicly available place-based attributes. And then we let people explore them through graphs and tables. Some simple statistical analyses that are growing over time, and then maps. So a pretty simple approach for a problem that has been hard to solve, at least traditionally for us. And it's been very hard, in particular, for sites to work together across institutions. We put our stuff on GitHub. We tend to, whenever possible, use national standard measures from CMS and NQF. We use the value set authority to put together our concept sets and our OMOP repository as well. And then, as I said, we're using OMOP now, but we really want to be able to support all kinds of different common data models and have the communities that support those models adapt our scripts to that type of work. If you go to our GitHub, you can see the measures that we already have. These are really just the foundational set that focus on preventive services, medical and behavioral conditions, social drivers like homelessness and food insecurity, a growing number of infectious disease topics, and then disability. And so by putting these all in one place, we're able to play around with the data and do all kinds of cool things. I won't go into super detail, but we spend a lot of time building out our specifications. You can go to the GitHub and see the measure specifications. You can see the underlying concept sets so that we try to be really as transparent as possible. In our code, we store all these concept sets in a data repository so they can be used by the code and run pretty efficiently. And at the end of the day, what we think we have here is a way to begin to leverage the incredible resources that we have in common data models across the US. We love that this model is mostly distributed. We do share patient level data, but we don't share dates, so that a lot of the work can be done locally. As I said, we don't share exact dates. The data owners can choose what to share, so it isn't like giving all of your data to a place, but you can agree that we want to share data about hypertension and diabetes, but maybe we don't want to share data about autism. So an institution could decide to do that much more easily in this framework. We're super transparent, so anyone can look at our code and decide if we did it right or not, and we can fix it. And we want to build out our library of functions, so this can the tool can really support all kinds of different stuff in the future, including maybe a little AI, which we don't have right now. And then most recently, and I'll say a little bit more about this at the end, we're starting to use privacy-preserving record linkages between Tufts and BMC, and we're going to have that by the fall, where we can begin to piece together the data sets from across the city of Boston to create a consolidated registry for all the people, or as many people as we can include within the city. And I won't kill you with a huge demo, but here's a quick tour. So you start at a homepage. On the left, you'll see there's kind of exploring health outcomes. There's doing some basic analytics, and then there's some mapping on the left. This is just blood pressure control for people living in Boston. This particular database includes BMC and 6 of our federally qualified health centers over time. Super easy to slice and dice the data by demographic features. So this is age group. On the right, you can get into tabular data to look at the data. You can see missingness in the data too, in the tables. This is looking at race and also neighborhood. So we aggregate zip codes by neighborhood, so it's possible for our partners at the Boston Public Health Commission to look at blood pressure control by neighborhood, for example. And then we can even reuse some of the health outcomes as predictors. So this is about blood pressure control among people with well-controlled diabetes versus poorly controlled diabetes. And as you'd expect, having controlled diabetes is also associated with a controlled blood pressure. You can explore the data a little bit variable by variable if you want to. You can do some univariate regression if you want to. You can look at multivariate regression as well. And then you can, we've started experiment with a little bit of machine learning. So this is just trying to explore variable importance. So which are the most important variables in predicting blood pressure control within this population. And then finally, we have some simple mapping tools. We're on the left, that's blood pressure control by zip code. In the darker areas are the more poorly controlled populations. And on the right, the Child to Opportunity Index, which is a sort of marker of economic and educational well-being. And you can see there's obviously close correlations between those two features across the city. So that's a quick tour of the tool, and we would love to work with other folks who want to work with us to do that. The project that we're working on right now is in collaboration with Tufts. We're in our second year of funding with the Boston Public Health Commission. And the idea is that we would work with the commission to identify the highest priority health conditions for the commission. So they've looked at what we have, and in this coming year, we're going to be building new measures. They're very interested in chronic disease and infectious disease, particularly the quality of care for patients with HIV. So that's going to be our major focus for the coming year. And the idea is that we will use privacy-preserving record linkage to compute these outcomes at each site. Each site will be able to explore their own institutional visualizations within the PHX, but then we'll bring those together to an honest broker. We'll adjudicate or harmonize values for people who are in both systems and pick a final outcome for each year. And then we'll remove the identifiers and put them into a central database that will be institution agnostic and just reflect people who live in the city of Boston right now. And over time, we'd like to add more and more institutions from the city of Boston into that framework. And in my own area, I'm particularly interested in the health of children, so to grow it out in terms of pediatric and child health. So it's not rocket science, but it has taken a while to get here. I think the consistency and the transparency and the utility of it all seem viable, and there's a lot of excitement right now in trying to bring folks together to really understand health on a population level and get beyond our sort of institutional frameworks.
Thank you, Bill. Sorry, I couldn't see the slides from over there, so I have to sit over there. That's very good. Very nice slides. Okay. Next is Jamal Matthews. She's going to talk about the Wisconsin Health Data Hub, and she's Associate Dean for Informatics and IT at the University of Wisconsin.
Thank you, Sean. Thanks, everyone. Before moving to Wisconsin, I was working at Dana-Farber Cancer Institute for about 10 years, and then as the chief of informatics at UMass Medical School. So I've seen the evolution of I2B2, and what was fascinating to me was hearing the Harvard dean talk for minutes about the technology in detail, and I've never seen a dean being able to do that. And it's a huge attestation to the work that Zach and Sean and others have done. So kudos and thanks for developing and maintaining this application. So the Wisconsin Health Data Hub is an attempt to pave the pathway for precision medicine and population health in the state of Wisconsin and beyond. So it's funded by the Economic Development Administration, and we are part of the Wisconsin's BioHealth Tech Hub, which brings together about 18 partners under the funding, and the lead consortium member is BioForward, and University of Wisconsin is one of the major players. What it does is it brings together 5 interconnected projects. 3 of them are technology projects. I'll talk about them in a minute. And our goal is to advance innovation, improve quality of life, and better health and healthcare for the Wisconsinites, and thereby bringing in significant economic growth to the state of Wisconsin. So Wisconsin Health Data Hub is an exemplar of the Wisconsin idea. So the University of Wisconsin has this principle that all the discoveries of the university has to reach the public beyond the 4 walls of the university and contribute to the health and well-being of Wisconsinites. So on the technology side, we want to enable discoveries in prevention, early detection, diagnosis, and treatment using big data and analytics. And we want to enable precision medicine and population health on the patient impact side. And Wisconsin has a lot of rural and urban areas, so there's a lot of divide in rural and urban care. And so we want to make sure that the solutions that are coming out using the data cater to both rural and urban populations in Wisconsin. And unlike Boston, we have significant challenges even in this project that we are trying to hire a lot of people. And I think there is significant opportunity in upskilling people in the advanced big data and analytics areas. So what problem are we trying to solve? You have heard Dr. Barrell today talking about the need for bringing data together. And this slide hopefully will illustrate that problem. So in a state like Wisconsin, we have a huge fragmentation issue in healthcare, both at the individual patient level and communities. So at the individual patient level, for example, we are the comprehensive cancer center, the only comprehensive cancer center in the state. And people move from their own hospitals to UW for seeking advanced cancer care. So we have a disconnect at the individual patient level unless we bring the data together. So what you see on the right side is active patient populations that are served by each of the hospital systems. These are 4 major hospital systems in the state of Wisconsin. So as you can see, UW-Madison, which probably has the largest population share of the state, is very much confined to the southern part of Wisconsin. And and similarly, the MCW and Aurora cater to the eastern regions or southeastern regions. And Marshfield, even though it's a smaller health system, it covers almost all the rural areas of the state. So unless we put this data together, none of us have the ability to address some of the problems across the state. And if we want to study geographical determinants or want to study the environmental milieu that affects human health, then there is no way for us to do it in a meaningful way unless we put the data together. So the objective of the Wisconsin Health Data Hub is to develop a framework for securely democratizing this data and bringing it together to fuel new treatments, companies, and jobs. From the get-go, we want to make sure that this is not just a framework for our academic curiosity, but also to enable entrepreneurship and for companies, whether it is large companies like Google or Microsoft or small AI development companies to come to Wisconsin or utilize the data. And so the way we are doing it is because these are hospitals in the same geographic vicinity that sometimes compete for the same patient population, we have to be respectful about that fact. And so we have a 2-prong approach. It's a hybrid approach. We have a federated query model built on I2B2 and Shrine to start with an OMOP underlying model, and then on-demand integration platform for approved projects. So we will be able to, like somebody will be able to query, identify the sites, and then do an on-demand integration. And the tools for on-demand integration are being currently developed. And, we can do this with large hospital systems. I think somebody alluded to that, maybe one of the questions. Even if we provide a lot of funding to rural hospitals, they may not be able to, because of lack of skill sets or other issues, convert the data into OMOP format or implement the I2B2 and do all that stuff. So what we will be doing to address those is to bring in the data using the state's health HIE network. So in Wisconsin, we have Vision, which is the state HIE, so we're bringing in the data. We are creating a governance framework that supports collaborative entrepreneurship and also developing secure enclaves for detailed analysis of the data that we will assemble on demand. And obviously, in our enclave, we have a plethora of public and private data sets that are of relevance that people will be able to integrate and apply AI and ML technologies for their research projects or innovation projects. And ultimately, we are trying to develop a clear, sustainable structure for continuing this beyond the grant cycle. So there are, one of the things, like I said, according to the Wisconsin idea, we want to make sure that as we develop all these technologies, the 3 technology projects are combining hands and saying that we want to have a demonstration project that demonstrates statewide impact over this 5-year grant period. So the Project 1 Wisconsin Health Data Hub, for example, will integrate clinical data from 4 large hospital systems in breast, lung, pancreatic, and colorectal cancer. And we will link it with the public and state data sets to identify areas where cancer screening is critically needed. And then Project 2, CareScan, which actually implements mobile screening using mammography, PET scans, and MRIs eventually. So the mobile vans will be sent to these areas by the Medical College of Wisconsin, to areas that are deficient in screening capabilities. And ultimately, GE Healthcare is developing a theranostics toolkit, and I'll talk about in a second. So the CareScan mobile screening, for example, will utilize the data, like I said, identify the areas where screening makes sense, and they'll send the vans. The screening data or the scanning data, the images will come back to the Wisconsin Health Data Hub, along with all the community level data that they can collect while they are at the sites. And so we believe that this will actually help cater to the needs of the rural communities particularly, and also in urban areas which are deficient sometimes in screening and other care. So eventually it will impact and help develop healthier communities. And so the GE Healthcare project then will take that data, imaging as well as the combined clinical data, and then make it available to providers along with the treatment suggestions. And initially, they'll focus on theranostics, so which is the advanced care that is now available for some of these cancers. So we believe that the combination of these 3 projects will provide a national model for integrating the data statewide, addressing a huge problem in terms of deficiencies in cancer screening in many areas, and also provide care solutions for providers and patients. So while we are doing that, we are also hoping that this will provide a framework again for people to come, both innovators and researchers, to ideate and assess the opportunity using our patient population, prototype the tools, do the clinical evaluations, and ultimately do the product development and clinical deployment. So I'll stop there. Again, I went too fast probably. It's a huge project, and a lot of people work on this internally as well as our sites and collaborators. So I'll stop there. Thank you.